بسم الله الرحمن الرحيم. كل سنة وحضراتكم جميعا طيبين. أنا الدكتور محمد النعماني، أستاذ واستشاري أمراض القلب بكلية الطب جامعة المنوفية. First of all, I would like to thank the Egyptian Society of Cardiology and the IRIS Event Management for arrangement of this highly educational series of cardiology lectures. My lecture for today is Management of Cardiovascular Disease Risk Factors in Hypertensive Patients Beyond the Blood Pressure. As we all know, the last guidelines and recommendation of European Society of Cardiology, European Society of Hypertension in 2018 as regarded the management of arterial hypertension. It classified the office blood pressure and the definitions of hypertension grades into optimal, normal, and high normal grades, and the grades of hypertension into grade 1, grade 2, and grade 3, with definition of isolated systolic hypertension defined as systolic blood pressure equal or more 140 and diastolic blood pressure less than 90 millimeter of mercury. Office blood pressure treatment target range. For all patients categories, regardless the associated comorbidities and the age of the patient, you have to achieve diastolic blood pressure less than 80, ranging between 70 and 79 millimeter of mercury. If the patient is between 18 and 65 years old, you have to achieve systolic blood pressure target less than 130, not going down 120. But if the patient have a chronic kidney disease, or the patient is older in age, more than 65 years or 80 years, you have to have a higher target of systolic blood pressure. Your target is less than 140 millimeter of mercury, but not going down to 130 millimeter. Factors influencing cardiovascular risk in patients with hypertension include the demographic characteristics and the laboratory parameters, where male gender is associated with more risk than women, age, smoking, current or past history, total cholesterol and HDL cholesterol and their ratio, uric acid, diabetes, overweight or obesity, family history of premature cardiovascular disease, family or parental history of early onset of hypertension, early onset menopause, sedentary lifestyle, psychosocial and socioeconomic factors, heart rate, where resting values of the heart rate more than 80 beats per minute are an important independent risk factor for future cardiovascular risk in hypertensive patients. So, an important target in your hypertensive patients beyond the blood pressure control is achieve control and reduction of heart rate of the patient less than 80 beats per minute. Another factors influencing cardiovascular risk in hypertensive patients are asymptomatic hypertension-mediated organ damage, includes arterial stiffening, pulse pressure in older people more than or equal 60 millimeter of mercury, carotid femoral pulse wave velocity more than 10 meter per second, left ventricular hypertrophy detected by ECG or echocardiography, microalbuminuria or elevated albumin-creatinine ratio, moderate chronic kidney disease with eGFR between 30 and 59 milliliter per minute per square meter, ankle brachial index less than 0.9, indicative of distal extremity vascular disease, advanced retinopathy, hemorrhage, exudates, or papilledema. Another risk factor is established cardiovascular or renal diseases in hypertensive patients, including cerebrovascular disease, ischemic stroke, cerebral hemorrhage, TIA, coronary artery disease, previous myocardial infarction, angina, myocardial revascularization history, presence of atheromatous plaque on imaging, heart failure including heart failure with preserved ejection fraction, peripheral arterial disease, atrial fibrillation, severe chronic kidney disease with eGFR less than 30. So, you have to pay attention in your hypertensive patients to all these risk factors beyond the figure or the number of blood pressure. So, according to the risk profile of your hypertensive patients is classified according to the stage of hypertension, the blood pressure level, the presence of cardiovascular risk factors, hypertension-mediated organ damage, or comorbidities. The classification may be very high risk, moderate risk, and low risk. For example, you may have a patient with high normal blood pressure but at very high risk category depending on the presence of other comorbidities and risk factors like chronic kidney disease grade more than 4, diabetes with target organ damage. While on the other side, you may have hypertensive patients grade 3 only in high risk category because this grade 3 hypertensive patient does not have any other risk factors or hypertension mediated organ damage or other comorbidities. Hypertension and the cardiovascular risk assessment. Cardiovascular risk assessment with the score system is recommended for hypertensive patients who are not already at a high or very high risk due to established cardiovascular or renal diseases or diabetes or markedly elevated single risk factor like cholesterol or hypertensive left ventricular hypertrophy. This is class 1 level of evidence B recommendation. Score risk assessment, systematic coronary risk evaluation for high and low cardiovascular risk charts based on the gender, age, total cholesterol, systolic blood pressure, and smoking status with relative risk charts, qualifiers, and instructions. These are the European high risk chart and European low risk chart depending on the scoring system. These risk charts including gender data, either woman or men, smoker or non-smoker, systolic blood pressure, and the cholesterol level. According to these risk charts, we have to risk stratify our patients before the treatment of hypertension to know the risk profile and the risk category of our hypertensive patients. Benefits of the scoring system based on the large data sets tested thoroughly on European data, operates with hard reproducible endpoints depending on cardiovascular death. Risk of coronary artery disease and coronary heart disease and stroke death can be derived separately, enables the development of an electronic interactive version of the risk chart. The score risk function can be calibrated to each country's national mortality statistics. According to the scoring system and the risk charts, the 10-year cardiovascular risk categories for cardiovascular and hypertensive patients including 4 categories. Very high risk, moderate risk, and low risk. Very high risk category includes patients with documented cardiovascular disease, either clinical or unequivocal on imaging, including a clinical cardiovascular disease like acute myocardial infarction, acute coronary syndrome, coronary or other arterial revascularization procedures, stroke, TIA, aortic aneurysm, and peripheral arterial disease, or unequivocal documented cardiovascular disease on imaging, including a significant plaque, more than 50% stenosis on angiography or ultrasound, diabetes mellitus with target organ damage, severe chronic kidney disease with eGFR less than 30 milliliter, calculated 10-year score more than or equal 10%. For the high risk category, it includes patients with marked elevation of a single risk factors, particularly total cholesterol more than 310 milligram per deciliter, or familial hypercholesterolemia or grade 3 hypertension, or most other people with diabetes except those with type 1 diabetes mellitus, hypertensive left ventricular hypertrophy, or moderate chronic kidney disease with eGFR between 30 and 59 milliliter, or patients with calculated 10 years score risk between 5 and 10%. For the moderate risk category, it is a calculated 10-year score of 1 and less than 5%, or grade 2 hypertension, or many middle-aged people belonging to this category. For low risk category, it includes people with calculated 10-year scoring risk less than 1%. Risk modifiers including cardiovascular disease risk, estimated by the scoring system, including social deprivation, which is the origin of many causes of cardiovascular diseases, obesity measured by body mass index, and the central obesity measured by waist circumference, physical inactivity, psychosocial stress including vital exhaustion, family history of premature cardiovascular disease, autoimmune and other inflammatory disorders, major psychiatric disorders, treatment for infection with human immunodeficiency virus, atrial fibrillation, left ventricular hypertrophy, chronic kidney disease, obstructive sleep apnea syndrome. Routine workup for evaluation of hypertensive patients, including hemoglobin level and hematocrit, fasting blood glucose and glycated hemoglobin, blood levels including total cholesterol, LDL cholesterol and HDL cholesterol, triglycerides, blood potassium and sodium, blood uric acid, blood creatinine and EGFR, blood liver function test, urine analysis, microscopic examination, urinary protein by dipstick test, or ideally albumin creatinine ratio, and finally 12 lead ECG. According to the latest recommendations and the guidelines of European Society of Cardiology, European Society of Hypertension 2018 for the management of arterial hypertension, adoption of lifestyle changes in patients with hypertension. It includes the following recommendations regarding the lifestyle. Salt restriction less than 5 grams per day is recommended. It is recommended also to restrict alcohol consumption. Both are class 1 level of evidence A. It is recommended to avoid binge drinking, increase the consumption of vegetables, fresh fruits, fish, nuts, unsaturated fatty acids, olive oil, low consumption of red meat, and the consumption of low-fat dairy products are also recommended. Body weight control is indicated to avoid obesity, defined as body mass index more than 30 kg per square meter, or waist circumference more than 102 cm in men and more than 88 cm in women, and aim at a healthy body mass index about 20 to 25 kg per square meter, and waist circumference value less than 94 cm in men and less than 80 cm in women to reduce blood pressure and cardiovascular risk. Regular aerobic exercises defined as at least 30 minutes of moderate dynamic exercise on 5 to 7 days per week. All are class 1 level of evidence A recommendation. Also, smoking cessation and supportive care and referral to smoking cessation programs are recommended as class 1 level of evidence B. Treatment of cardiovascular risk factors associated with hypertension. Cardiovascular risk assessment with a score system is recommended for hypertensive patients who are not already at a high or very high risk due to established cardiovascular disease, renal disease, or diabetes. For patients at very high cardiovascular risk, statins are recommended to achieve LDL cholesterol level less than 70 mg per deciliter or reduction more than or equal 50% of the baseline. For patients at a high cardiovascular risk, statins are recommended to achieve LDL cholesterol goal less than 100 mg per deciliter or reduction more than or equal 50% of the baseline. For patients at a low risk to moderate risk cardiovascular disease, statins are to be considered to achieve LDL cholesterol less than 150 mg per deciliter. Antiplatelet therapy, in particular low-dose aspirin, is recommended for secondary prevention in hypertensive patients. It is class 1 level of evidence A, while aspirin is not recommended for primary prevention in hypertensive patients without cardiovascular disease because of higher incidence of bleeding. Managing concomitant cardiovascular disease risk in hypertensive patients. Statins and lipid-lowering drugs. Patients with hypertension or type 2 diabetes or metabolic syndrome often have an atherogenic dyslipidemia. Adding a statin to antihypertensive treatment was well established in adequate lipid-lowering arm. Beneficial effect of statin administration to patients without previous cardiovascular events targeting an LDL cholesterol value less than 150 mg per deciliter have been strengthened by Jupiter and HOPE-3 trials. Lowering LDL cholesterol in patients with baseline values less than 130 mg per deciliter reduced the incidence of cardiovascular events by about 24 to 44%. This justifies the use of statins in hypertensive patients who have a moderate to high cardiovascular risk. Antiplatelet and anticoagulant therapy in hypertensive patients. Hypertension predisposes to a prothrombotic state and lower extremity arterial disease, heart failure, or atrial fibrillation, which are common conditions associated with thromboembolism, whether systemic or venous. Aspirin did not reduce stroke or cardiovascular events compared with placebo in primary prevention in patients with elevated blood pressure and no previous cardiovascular disease. For secondary prevention, antiplatelet therapy had an absolute reduction in vascular events by about 4.1% compared with placebo. No benefit for anticoagulation therapy alone or in combination with aspirin in hypertension in the absence of atrial fibrillation or venous thromboembolism. Bleeding history or predisposition or labile INR or older age more than 65 years or concomitant drugs like alcohol or other bleeding promoting medications or uncontrolled hypertension defined as blood pressure more than 160 millimeter mercury for the systolic reading are all risk factors for increased risk of bleeding, and these should be used as flag up patients, in particularly high risk patients with Has-Bled score more than or equal 3, for more regular review and follow-up of your hypertensive patients. In anticoagulated patients, uncontrolled hypertension is one of the independent risk factors for intracranial hemorrhage and major bleeding. In such patients, attention to modifiable bleeding risk factors should be made during all patients' contacts. Uric acid is another independent risk factor in hypertensive patients. A strong association exists between hyperuricemia, hypertension, and cardiovascular diseases. Large interventional studies are needed to determine if reduction in uric acid level can prevent hypertension and major cardiovascular events, especially in young population with pre-hypertension. Although allopurinol generated a large interest, this medication has several pitfalls. With newer and more specific xanthine oxidase inhibitors, there is a renewed opportunity to further test the hypertension uric acid hypothesis and to improve our understanding of the possible cardiovascular consequences of elevated uric acid levels. Glucose-lowering drugs and blood pressure in hypertensive patients. New glucose-lowering drugs proved to have a favorable impact on blood pressure and reduction in cardiovascular and renal risk beyond their effect of glucose control. DDP4 inhibitors and glucagon-like peptide-1 agonists reduce blood pressure and body weight with reduced cardiovascular and total mortality, but not heart failure in type 2 diabetes. SGLT2 inhibitors are the only glucose-lowering drug class to reduce blood pressure beyond the projected impact of weight reduction on blood pressure improvements. Empagliflozin, dapagliflozin, and canagliflozin demonstrated a reduction in heart failure and the total and the cardiovascular mortality and the protective effect on renal function. Increased sodium excretion and improvements in tubulo-glomerular balance, reducing hyperfiltration are suggested mechanisms for the observed cardiovascular and renal protection. Finally, in conclusion, my take-home message: cardiovascular risk assessment to guide treatment thresholds and the intensity would help to move blood pressure management away from just arbitrary cutoff points to a personalized treatment strategy geared toward the cardiovascular risk and the potential for benefit of the individual. So finally, you have to risk stratify your hypertensive or cardiovascular patients. Treat your patient as a global cardiovascular risk profile, not only the blood pressure figures or blood glucose levels or the lipid parameters. And finally, thank you.